Hello, everyone, and welcome to our IMPART Research Reels webinars. We are delighted about the new webinar series the IMPART team is hosting. Before we get started, I would like to introduce it to you all. So who is IMPART? IMPART Investigator Team is a national virtual research institute headquartered at Dalhousie Medicine, New Brunswick in St. John. Our team is composed of 45 academic and clinical partners across 8 universities and 6 provinces, as well as 25 community and funding agency members, 15 private sector company representatives, and 2 provincial government departments. IMPART's mission is to think boldly and utilize our network to improve the outcomes of vulnerable patient populations, starting always with innovation developed and tested in New Brunswick. We apply intersectional thinking between social and medical innovation and have brought together a diverse and inclusive team of experts to support activities from fundamental research to applied interventions with vulnerable populations. So what is this webinar about? The Research Reels webinar series will host monthly webinars by IMPART team investigators and trainees on ongoing or completed research within the network. The objectives of this webinar series are to improve networking among IMPART team members, enhance opportunities for future collaborations, and support knowledge translation of research findings. So if you would like to nominate a speaker for our upcoming Research Reels webinars, please do so in our post-webinar surveys. IMPART is also present on social media, so please follow us on our social media outlets. Also, if you have missed any Research Reels webinars, you can go on our YouTube channel, Research IMPART, and access them. I am beyond excited to introduce to you today's speaker, who is Dr. Jean-François Légaré. Dr. Jean-François Légaré joined the New Brunswick Heart Centre in September 2016, assuming the role of Division Head of Cardiac Surgery. He has made important contributions to the cardiac care of New Brunswickers, including implementing strategies to reduce wait times and increase the efficiency of care while maintaining quality. His vision for the Heart Centre is to provide world-class cardiac surgical care for the province of New Brunswick and be a national leader in the type of procedures offered at the New Brunswick Heart Centre. Dr. Légaré obtained his medical degree from McGill University in Montreal from 1991 to 1995, cardiac surgery training at Dalhousie University 1995 to 2002, and Herzsturm in Germany, and I may need your correction, Dr. Légaré, in 2003. Upon returning to Canada, Dr. Légaré joined the cardiac surgery division in Halifax, Nova Scotia, 2003 to 2016. During that time, he was the Director of Research and Surgical Director of Transplantation in the Division of Cardiac Surgery with Dalhousie University. Dr. Légaré is an established clinician scientist and professor of surgery at Dalhousie University with cross appointments in pathology and microbiology, immunology at Dalhousie University. He has been recognized nationally for his leadership by sitting on the executive of the Canadian Society of Cardiac Surgeons and acting as past president of the society from 2018 to 2020. Now I will pass the floor to the speaker itself.
Perfect, Natalia. Thank you so much. So let me share my screen and whoop. Make sure this shares there. There we go. Hopefully you can see that.
Perfect, yes.
I'm going to put a laser pointer. Now the laser pointer, do you see it here?
Yes.
You do, perfect. Anyways, thank you very much for the opportunity. So today I was going to talk to you a little bit about something that's really close to the heart to me. And it's really trying to link back what we do clinically, ask research questions, and try to impact the care we provide a patient. So the title is What's All the Fuss About Having a Shock Team at the New Brunswick Heart Centre? So what is cardiogenic shock? And this is really, while it seems like a simple concept, it's sometimes difficult to explain or to grasp, but essentially it means a life-threatening condition in which your heart suddenly cannot pump enough blood to meet your body's demands or needs. The condition is most often caused by a severe heart attack that damages enough of the heart muscle, but it could be caused by other things. So what we see essentially is when you have a heart injury in the form of a heart attack, for example, that can affect enough the myocardium to reduce its ability to pump blood. So we call that the decrease in cardiac output. And that would manifest itself from a clinician point of view in lower blood pressure and all sorts of things that would go with that. You'd have your hands would be cold, you'd be vasoconstricted. Eventually you'd have less blood flow to all your vital organs. And eventually that would lead to eventual death. So it is more than the effect to your heart muscle, it is effect to the entire body, leading to multi-organ dysfunction. So cardiogenic shock is a really dangerous problem, and it creates a cycle of problems that eventually one is unable to get out of. So why is this a clinical problem? Well, it's a clinical problem for several reasons. One is not all heart injuries are the same. It's sometimes very difficult to recognize or sometimes quantify how much heart damage occurs during a heart attack, for example. So it's difficult, one, to quantify or to recognize. Two is some heart injury can be quite severe, others are not and can lead to organ failure, but the signs of organ failure are often quite subtle and can be as subtle as someone's a little drowsy, a little sleepy, a little, their hands are cold a little bit. There's basically the body has all these compensating mechanisms that before your organs die, you create these or you implement these mechanisms, but they actually are on your way to dying as you are clinically. And finally, there are very few treatments that have been proven to be effective. So this is why cardiogenic shock is such an issue. And so if you were to state the problem again, is we have a common condition, for example, heart attack or myocardial infarction, where blood vessels would get blocked, you'd get an area of your heart muscle that would die. The majority of patients are treated for this. They come to the heart center and have appropriate therapy for this and survive this. But there are a proportion of these patients that develop cardiogenic shock, and that occurs between 5 to 8 or 5 to 10% of every single patient that comes to the heart center with a heart attack. So it's relatively common. And the mortality in patients who develop cardiogenic shock is very high. It ranges between 30 and 60%. Again, highlighting that any intervention that we can do that would improve their outcome potentially would help. And finally, I mentioned to you, there's limited evidence from trial of things that can help. The really only evidence we've been using or working with in the last 20 plus years was published in 1999. This is a shock trial. This was a landmark trial and not a very big trial. As you can see here, there were 150 patients per arm. They were randomized. Essentially, they presented with shock. Patients that essentially would receive revascularization. That means somehow we brought blood flow back to the area of heart attack, either by percutaneous means like angioplasty or with surgery. These patients had a better survival than patients who were given medications only. So that really has impacted the treatment of shock since then, that we would advocate for early intervention in the form of revascularization. But what about other therapies? There's really not a lot of evidence for how we can help outcomes in these patients. And if you look at the outcomes, they're still pretty terrible. 30-day mortality here in these groups were around 50% of patients were dead at 30 days. So in January of 2019 at the New Brunswick Heart Centre, there was a strong desire to improve outcome in our shock patient. So, and we believe that our mortality was higher than 35%. We wanted to do something about that. And we also wanted to address newer literature that had come out in the last few years from 2016, 2017, suggesting that if a team was implemented, one could improve outcomes. It was about process of care, not just one treatment or one strategy. It was about having groups of individuals together with different perspective on a problem that could actually modify or help outcomes. And then we created a series of meetings and eventually came up with a protocol. So this was really a follow-up to this type of evidence where contemporary management of cardiogenic shock was being written about, and from leaders in Canada like Sean Van Diepen, who's in Edmonton, as a critical care specialist, and this was published in 2017, and numerous other papers supporting that, basically evidence suggesting that the creation of a standardized process when patients were identified and creating an algorithm by which once patients are identified, what critical things need to happen, how do you improve communication, How do you improve treatment? How do you limit delays? How do you triage these patients? And this is not an algorithm I want to get into with you because it's a little bit blurry there, but just to illustrate that some of these things had been published. So we worked in 2019 in designing an algorithm that would work for us at the New Brunswick Heart Centre. And this is what we created. We created a code shock protocol in which we would divide into 4 steps. So step 1 was really the identification of patients in shock that were admitted to the coronary care unit. And they needed to have 2 things. One is signs of low blood pressure, so a measured blood pressure that was low, and signs of hypoperfusion. That would mean basically lack of blood flow to some organs. And that would be basically an example of that was a low urine output. So if your kidneys don't produce enough urine, that means they're not getting enough blood flow. That means theoretically your kidneys think you're dry, but you're not. It's just a lack of blood flow that causes that. That's one way. And there are other biomarkers you can measure that would measure hypoperfusion. So once a patient was identified as cardiogenic shock, then there was a discussion amongst the treating, the nurse, the resident, and obviously the CCU staff to identify that patient. And once that patient was identified, then an activation of the code shock was done, which would essentially just bring together in real time to have a conversation virtually by phone or by Zoom time. And we plan in Zoom at that time through our phones, is to have the CCU attending, which was the intensive care physician that was taking care of that patient, the interventional cardiologist on call that day, and the cardiac surgeon on call that day to really discuss the patient and come up with a strategy, a plan, how we would approach goals of care. Are we too late? Are we not? Is this a patient that's a candidate for intervention or not? Because some patients you might choose to do palliation instead of aggressive treatment, depending on the circumstances. So this was implemented essentially in December of 2019. So today, I was going to present a little bit my thoughts and some of the data that we've managed to obtain from a 12-month period where we screened all patients admitted to the coronary care unit at the New Brunswick Heart Centre, and to assess the role of the shock team had in that group, understanding that we took the entire year prior to that to prepare ourselves to set the protocol in place and the education required for that. And so this is a kind of screening that was done. Every single patient was to be screened by the nurse at the bedside every single shift. There's 2 shifts a day for every patient in the coronary care unit. And this is a classification. They would basically classify their patient as a stage A, B, C, D, or E. Stage C, D, or E are shock stages. The classic shock that I mentioned to you with lower blood pressure and hypoperfusion is a classic stage C. A patient in class D means that they're deteriorating despite interventions that you've done to try to reverse the shock state. And in stage E, they're dying, they're before death. So these are the stages of shock, while stage A and B were believed to be not in shock. So during that period of time, a total of 1,014 or 1,400 patients were admitted to the coronary care unit, the majority of which, as you might imagine, did not have shock. They were in stage A or B, but there were nearly 100 patients that were in shock. A number of them were non-cardiogenic. They were infectious, most of them. So endocarditis would be the most common reason. And these patients in shock consisted of a group of 80 patients, only 35 of which a shock team was activated. So perhaps a missed opportunity here. This is, again, why we're doing this work and why we're doing this. But note that there were 240 patients that were not screened. So they were admitted. So that's 20% or so of patient not screened. But having said that, I'll explain to you a little bit why. So this looks on a monthly basis, the 12-month period in which patients were screened. In gray are the percent of not screening failures or non-screening. Most of the non-screening occurred during these 2 months, which were the months of March and April of 2020, which was the beginning of the pandemic. So this was a hard month, obviously, for everybody. Lots of things were going on and happening, so perhaps understandable. But it does illustrate that in the majority of the time, more than 85% of patients are screened. And most patients, as you might imagine, are not in shocks in blue, but there are some patients in yellow that are in shock stage C to E. So screening is critical to the implementation of any treatment strategy. So we demonstrated that this is feasible, this is doable, and overall we screened the majority of patients. Having said that, we also identified some pretty significant gaps that need solution. And some of the work we're doing now is trying to implement and trying to find solutions for this. So screening needs to remain part of care. And that's something that's always hard a bit in medicine, because it's often perceived as added work if people don't understand why we're doing these things. And there's not an obligation to do these things, or to record this, or to capture this in the data in a retrievable manner. And many things we do in medicine are not necessarily always retrievable. We're able to retrieve this data for the 12-month period because this was part of the protocol we set, but we can't reliably retrieve that at the present time. So this is some of the gaps that we have often in medicines that are terribly frustrating in terms of implementing change. So what proportion of patients had shock? We identified 80 patients, 7% essentially of our population of patients who were admitted to the coronary care unit had cardiogenic shock. The majority of them were in the blue here in stage C, very small number in stage D, and a smaller number even in stage E. But you can see that still 7% of admissions out of 1,400 is still not a negligible number of patients, and that we can impact potential care. So, and more importantly, what was the outcome of these patients? This is probably the most illustrative slide that I have regarding that. Is you can see that the mortality risk, so if you don't have shock, you're admitted to the coronary care unit in this institution, your in-hospital mortality is only 2%. The majority of patients who come in, have a heart attack, come in with heart failure, variety of things, are treated appropriately, go home, and the majority of them successfully go home. If you have any form of shock, 33% of them die in hospital. So very high mortality rate. If you stage C shock, 25% mortality. Stage D, double that, 55%. Stage E, 100% of patients died. So clearly shock, and the later in your shock process, as I illustrated, it's a cycle, a vicious cycle of worsening problem, the less likely you're going to survive. Oops. So we obviously wanted a few questions that we had around that. Does geography impact mortality? Again, this slide, I want to be careful to make sure that it's very clear. The overall mortality of the entire population, including all stages A to E, was 4%. If you look at only shock patients, so C, D, and E, if they came from zone 2, the mortality instead of 30 was 40, so a little bit higher. Other zones in the province, 39. So the lower mortality came from patients that came outside of New Brunswick. We get about 15, 20% of our patients come from other parts of the other province, such as Prince Edward Island. And perhaps this is a little bit misleading in the sense that patients who were sicker may not have had the chance to survive, or not put in an ambulance for 6 hours to make it to us. Again, I mentioned time is critical here. So it is possible that we sub-select patients that come from further away and outside part of the province for making it to us. So what about the shock team? Did it have an impact? So if you were to look at this table, so 44% of patients triggered the shock team. So a group of 35 patients. So this is this column right here. And if you compare them to patients who were not in the shock team or not seen by a shock team, they were very similar in terms of age, or age greater than 70, female gender, or BMI was a little bit different. This is the only statistically significant group. Otherwise, there's a few trends that are worth noting. Is patients in the shock team group were less likely to be from the zone 2, were more likely to be outside of New Brunswick or outside of St. John's. Sorry, that's a mistake there. And they were also more likely, the patient that were seen by the shock team, to be in stage D and E. There were several patients in those groups, and they were less likely to be stage C only compared to the non-shock team. So perhaps a sicker group of patients coming from other regions other than zone 2. So if you look also at the shock team in this table, if you look on diagnosis submission, but more importantly, the interventions that were created, all of the patients that were seen by shock team had more interventions. And interventions, I mean by that, is active intervention in the form of monitoring lines that help us make decisions that are critical for these patients, like arterial line, central venous catheters, PA catheters, which are lines that are put in directly in the heart to measure pressures and to test or to look at medications or interventions that we give, whether or not they're efficacious or don't. But it requires sort of invasive monitoring, and they are challenging sometimes. It also resulted in more interventions in the form of even surgery and even ECMO, which is mechanical support. I'm just gonna, 2 seconds, gonna answer that. Is the operating room, I'm sorry. Perfect. And you can see that obviously less in the non-shock team group. However, having said that, in this non-adjusted data set, you can see the shock team did not affect significant mortality. Mortality was 31% in the shock team group, was 35, a little bit higher in the non-team group. But remember, they were a little bit sicker group of patients. So perhaps, again, small group, we're not able to show a difference. So failure to demonstrate our failure to demonstrate a clear benefit here for shock team, I don't think means that we should throw the idea in the garbage. This is just how it work. I still think there's here much to learn going forward. So So we learned the following regarding mortality in our patients. We learned that it did not appear to be very much impacted by geography. But geography was looked in a very broad manner in terms of zones, zone 2 versus the rest of the province or versus Prince Edward Island. We didn't specifically analyze depending on distance. Is the patient coming from Campbellton different than a patient who comes from Moncton, for example? Very different question. So again, and the reason it's important is that distance, potentially time and time to delay or delays of variety of form can have a tremendous impact on survival potentially. So shock team did not appear to significantly impact mortality, but again, the shock patients were perhaps a little more advanced. So I'd mentioned this already. So what about other processes of care? Time of day, unexpected delays, those are all important things that I haven't addressed yet, but we're trying to look. And I'll just show the next slide because it is important when we think of delays. I mentioned that the shock stage C, D, and E, perhaps the D and E were further down the process, more delays in their treatment when we recognized it, and their mortality is much higher. But there's lots of evidence out there of this type of evidence where you can show that if a patient that presents in shock, there is more than 13 hours, this was in that group, the more than 13 hours before a clear definitive management is done, their mortality is exceedingly high compared to patients who were treated earlier, with less than 10% of patients surviving at 30 days. So it shows you that there's a point where you delay enough that all patients will die given the scenario that occurs. So what does this mean to all of us? So clearly we need to analyze and spend a bit more time with data. We have lots of data with this. We have biomarker data. We have time delays that we're trying to analyze. And this is a quote from William Osler that illustrates this, that to learn something, you need to learn all of the of observe, record, tabulate, communicate, use the 5 senses, learn to see, learn to listen, learn to feel, learn to smell, and know that practice alone can you make an expert. This is a classic quote from William Osler. For those of you who don't know, is a famous physician from Johns Hopkins and McGill University, who was my alumni. So I was at one point a member of the Osler Society. So in summary, I think the shock team can be successfully implemented in the cardiac surgical setting and in the New Brunswick Heart Centre. However, we have some major gaps in screening that we need to address and need to be worked out because it should be part of care. Shock is common. It occurs 7% of patients who are admitted to a coronary care unit with 65% of diagnoses that were not made on admission. That means they were made later. So clearly, there is a need for vigilance when you have these patients. Mortality remains very high, 33% for shock patients compared to 2%. It's twofold higher for stage D if you delay. It's 100% if you delay to stage E. A fourth point is that the shock team was mobilized in only 44% of the cases. I am sure there's some missed opportunities here. I'm sure we could have done better for some of those patients. So what were the barriers? Why did we not elect to mobilize the shock team? So we need to obviously address that as we go forward. And finally, the shock team clearly resulted in more invasive monitoring, more interventions, but no mortality benefit, but perhaps in sicker patients. So perhaps what we're looking at is the outcome here, because these are, remember, unadjusted outcomes is not really what we should be looking for. So for example, in other centers, such as in Ottawa, they were never able to show a short-term mortality benefit, but they were able to show a 6-month mortality benefit. So clearly there are patients, perhaps it's the functional recovery after. There are other aspects of this that a shock team and early implementation of certain things may resolve. So with that, I will end, and thank you very much. Let me stop sharing, and I'm back on.
Thank you so much, Dr. Légaré, for your detailed presentation. If any of our webinar participants have any questions, please feel free to address them in chat. We're in the Q&A box. I have a question. How did the pandemic, the past 2 years, have affected or would have affected the results of your study?
Yeah, I mean, you saw on the screening, there's no doubt that most of healthcare staff have felt relatively pressed for their work and added duties and responsibilities, and it's essentially felt like everything we've done normally, we have to do it, and you have the added screening, the added other aspects of that. So all the change in rules, change in limitation, testing, gowning, isolation, retesting, are you contact, are you not contact? So it added all of these layers that I'm sure added more work. So when you asked them to screen for this was just, oh my God, there's one more thing we got to do. So there's no doubt that it adds that. So there's some fatigue in general. So if the general public feels fatigue about COVID, I can tell you the healthcare staffs are feeling really fatigued by COVID. It just feels like it's part of everyday life. You know, we have part of our staff that are gone most of the time, and we have patients that isolate and contacts, and we have to change things all the time because of it. So I'm sure it's affected everybody.
Thank you. Any other questions from our attendees? I don't want to take any longer from Dr. Légaré's busy schedule. It doesn't look we have questions. Dr. Légaré, thank you so much for taking the time to present today.
Thank you.
Have a wonderful day.
You too. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.